must first of all make it clear that I don't consider the present configuration of the NHS should be set in stone, but I do believe that the government's plans transferring the commissioning and funding of NHS hospital services from primary care trusts to general practitioners and other changes affecting the National Health Service which are proposed, I believe that these can only be justified by two conditions. Firstly, that there are serious failings in the current provision, and secondly, that there is convincing evidence that any such failings will be relieved by the action proposed. Regarding the first concern, earlier today I had a minor operation at Calderdale Hospital, which thankfully confirmed that all was well following the previous major operation. My treatment was, as on previous occasions, both efficient and caring, and I believe this is the experience of most patients. Unfortunately, however, there is considerable evidence that in a minority but significant number of cases this is not so, and thus, as reported in the Halifax Courier in the last year or so, a survey by the NHS watchdog, the Quality Care Commission, in 2010 showed NHS Calderdale ranked among England's worst providers in 5 of 38 service areas, with 25% of staff witnessing, and I quote, at least one error which could have hurt staff, patients or service users in the past month. And on staff gradings of other services from 1 to 5, with 5 being likely to recommend, the average was only 3.65. And the report also found that 36% of staff complained of work-related stress, a fact which didn't deter the NHS Calderdale's chief executive from claiming that the survey suggests we are one of the best NHS employers in the country. An earlier official Healthcare Commission survey found that 38% of Foundation Trust staff would be unhappy at being treated in its hospitals, putting it among the worst results in Yorkshire. A recent Trust report also reveals high and rising number of bed sores in Trust hospitals. Other reports in 2010-11 include the case of an elderly man admitted to Calderdale Road with minor injuries, who was twice allowed to fall out of bed, breaking first his wrist and then his hip. One fall out of bed is excusable, but for this to be repeated is really not at all satisfactory. And there was also a case of a baby whose death the coroner concluded was in part due to negligence at Calderdale Road. And I personally am visiting one of the wards to see a patient, witnessed an old lady wearing an oxygen mask carrying out for water. A glassful was eventually brought and placed out of her reach on the bedside table, and she was left without the mask being removed or being offered much needed assistance. Finally, and perhaps most worrying, Calderdale Royal Hospital's own investigations in a report copied to me by his widow admitted serious neglect of her elderly husband over a period of 7 months prior to his death, the day after discharge home. The incidents acknowledged included visitors repeatedly finding him lying in his own excrement, undue delay in giving prescribed antibiotics, and pain relief, and the placing of food and drink out of reach. So sadly, local hospitals are clearly not always free from the poor standards of elderly care, which have been highlighted recently by the Health Services Ombudsman, making the claim in the latest Foundation Trust letter that its services are judged the best in Britain seems seriously complacent, to say the least. Changes in NHS administration locally are not therefore without justification, but nevertheless I share the concerns of the British Medical Association the Royal College of Nursing, and as voiced at the recent Lib Dem conference and by Unison, regarding certain aspects of the government's proposals. These include the fear that the additional administrative commitments involved on top of their clinical workload will adversely affect the patient care delivered by GPs. And it's certainly imperative, in my view, that other experts, including consultants, nurses, care assistants, and appropriately experienced administrators, should be included in any such consortia. And also that elected bodies, such as local councils, be involved in the decision-making and regulation of consortia. The prospect of more patients being treated in the private sector, as happened under the previous government, also raises fears that this might lead to cherry-picking of uncomplicated cases and creeping privatisation, which certainly must not be allowed to occur. I'm also strongly opposed to suggestions that despite election promises that the NHS would be ring-fenced, cost-saving cuts in the number of doctors, nurses and other carers might be imposed. As reported in the BMJ, there has been disproportionate rises in the number and pay of NHS managers as compared to doctors, nurses and other carers. For instance, the salary of the Chief Executive of Calderdale and Huddersfield Trust has risen since 2006 by £80,000, well over 3 times the pay of a qualified nurse. And a lump sum entitlement has risen by £95,000, with similar increases for other managers. I believe the number and remuneration of managers should be cut down so as to finance the cost of maintaining nurse numbers and patient services. Hopefully pressure from Lib Dems and others inside and outside government and unions will result in the valid objections to GP-led consortia I have mentioned being satisfactorily resolved, and the benefits that are claimed to follow is demonstrated. In favour of the family doctors, it has to be said that they're in close contact with their patients and able to identify at first hand any poor care they receive. As members of influential consortia, they will be well positioned to ensure such deficiencies are addressed and remedied by those responsible. It is of interest in this regard that I have been informed that Calderdale GPs have already provisionally formed a consortium, with over 80% of them supporting the idea. And they're in discussion with the council regarding the coordination of social and healthcare services, which is obviously needed. In conclusion, I would make one further important proviso, namely that however the proposals for GP consortia and other NHS reforms are modified, and I think there will certainly be considerable modification, they should be subject to trial runs of 2 to 3 years in a limited number of trust districts and their benefits demonstrated before they are generally introduced. This would address the legitimate concerns that previous reconfigurations have been too frequent, too hasty, and failed to deliver the promised benefits.